Assalamualaikum. I'm audible to all of you. Okay, that's great. Everyone there, if you want to say anything to me, then kindly just unmute yourself and say directly, because during giving lecture, I do not see my chat box, okay? So if you want to ask any question or there's anything problem with my screen share or my voice, then just unmute yourself and tell me, okay? So, Assalamualaikum, I'm Dr. Sanamjad, and is our second lecture on anatomy module. See, the anatomy module is very big for MRCOG part 1, so we have divided into so many parts so that we will cover in almost 2 weeks, okay? So, starting today, previously in our first lecture, we discussed about abdominal wall. That was anterior abdominal wall, posterior abdominal wall, inguinal canal, and femoral canal, okay? That was very important for exam purpose as well. Now moving on to our next topic. Today we will discuss about the pelvis, okay? The pelvis, everything about pelvis, the pelvic bones, the joints, ligaments, and the very, very important diameters, okay? So starting today's lecture with these pelvic bones. So the bony pelvis is actually composed of 4 bones. See, one is the sacrum, this is the sacrum, and the second is the cox. These forms the posterior wall of pelvis. Then there are 2 innominate bones, which can be called the hip bone. Okay, so these are the 2 innominate bones, which form the lateral and anterior walls. And each this innominate bone or hip bone, it is formed by fusion of 3 bones: the ilium, up till here the ilium, then ischium, and the pubis. Okay, so the 2 hip bones, they articulate with each other anteriorly at the pubic symphysis. Like here, it will be they are forming anteriorly a joint. This is called pubic symphysis, and posteriorly with the sacrum. Here, they articulate with the ala of sacrum and they form the sacroiliac joints. Okay. So in the anatomical position, the front of this symphysis pubis and there is an anterior superior iliac spine. They should be lying in the same vertical plane. That's just they can ask in exam of the anatomical position of how you hold the pelvis and how the pelvis is held in the anatomically. Okay, so these 2 points actually line each other: the anterior superior iliac spine and the symphysis pubis. Okay. So we will discuss all these bones in detail because there are few very important landmarks on these bones that can come in exam. Okay. So first is the sacrum bone. It is formed by fusion of 5 vertebra. See, S1, 2, 3, 4, and 5. There are 5 sacral vertebra. All of them are fused in the midline. Okay, and there is a very important structure here. This is called sacral promontory. It actually represents the anterior border of upper part of sacrum, and this is a very important landmark for obstetric purpose as well. We'll discuss later on the sacral promontory purpose. Okay. Then anteriorly, the sacral bone consists of this central mass and the 2 rows of 4 anterior sacral foramina. See, these are the foramina through which the sacral nerve roots appear on both sides. Okay, so 4 S1, 2, 3, and 4 nerve roots go through these foramina. Okay, and then there's a lateral mass and then there's a ala. So this is the ala of the sacrum, which articulate with the iliac bone. See, there will be the articular surface. And posteriorly, if you see the posterior picture of the sacrum, then you will see this is the sacral canal through which all the nerve roots go down. And again, likely the interior foramina, there will be the posterior foramina. Through anterior foramina, anterior nerve roots go, and through the posterior foramina, posterior nerve roots go through these foramina. Okay, so again there are 4 posterior 4 rows of posterior sacral foramina on both sides. Okay? And then there is the sacral hiatus. The sacral hiatus, it actually, from this sacral hiatus, the S5 nerve root goes. Okay, so there are 4 foramina, and the sacral hiatus S5 nerve root transmits through the sacral hiatus. Then there's a sacral cornu, it has no significance, and there's a superior articular facet. See, this is the superior articular facet, and through which the lumbar, above the sacrum is the L5 vertebra, okay? So L5 vertebra attaches through this articular facet. So this is the landmarks of this sacrum bone. And then this is a very important exam question as well. The dural sheath terminates at S2. So in our previous lecture, we discussed that at L1, the spinal cord terminates, okay? And also we discussed that at S2, the dural sheath terminates. So these are 2 very important exam questions. You must have to remember this. And beyond which, below down the S2, the sacral canal contains only the fatty tissue of extradural space, the cauda equina, and the phylum terminal. Okay, so these few landmarks are very important, that at L1 the spinal cord terminates, and at S2 the dural sheath terminates. Okay, and what contains the sacral canal below the S2? It would be the fatty tissue, the cauda equina, and the phylum terminal. Okay, so this is a Cox bone. It has very little significance, and it is 4 vertebra. See, as sacrum bone has 5 vertebra, they were fused, and in Cox we have 4 vertebra. 1, 2, 3, 4. All of these are fused, and they form like this triangular Cox bone. Okay, it articulates with the sacrum, and there are the few. There's only the one transverse process upward. Okay, so this was all about the sacrum and Cox. Now coming to the hip bone, which can be called the innominate bone or hip bone. Okay, so basically in children, this hip bone consists of ilium, ischium, and pubis, but these 3 bones are joined only by cartilage at the acetabulum. See, this pink color is ilium. This is the landmark of ilium, and it joined in the acetabulum. And then this is the ischium, and then this is the pubis. Okay, so these 3 bones, they joined at the acetabulum. At puberty, these 3 bones then fuse together to form one large irregular bone. Okay, so after puberty, these 3 bones, they fuse and they form a single hip bone, you can say. Now there are a few important points on ilium bone. I'll be discussing ilium bone in next slide. You can see in this figure, this upward curved border, this is called iliac crest. Okay, and at the interior upper border, this is the anterior superior iliac spine. We can say ASIS like this. Okay, and there's anterior inferior iliac spine. Okay, and likewise in the posterior border, there will be a posterior superior iliac spine, and then the posterior inferior iliac spine, and then there will be a sciatic notch. Okay, so this is all about the ilium bone. These are the landmarks, and this anteriorly, this line is called the iliopectineal line. Okay, so see the next slide. See, this is the ilium bone. The ilium is the upper flattened part of hip bone. It possesses the iliac crest. So the iliac crest, basically it runs between the anterior and posterior superior iliac spines, and below these spines are the corresponding inferior iliac spines. Okay, both anterior and both posterior inferior iliac spines. On the inner surface of ilium will be the large auricular surface for articulation with the sacrum, because this ilium bone, they articulate with the ala of sacrum. Okay, like this. And then there is a iliopectineal line. This is a very important line for obstetrics as well, because it runs downward forward around the inner surface of ilium, and it divides the falls from the true pelvis. I'll be discussing in our next slides that what is the false pelvis and what is the true pelvis. Okay, so this is an important line, iliopectineal line. Then there's the ischium, and ischium has ischium is you all know that it's the inferior and posterior part of hip bone, and two important landmarks on ischial bone is the ischial spine and an ischial tuberosity. Okay, you must have remember that these 2 points are very important because sacrotuberous ligament and sacrospinous ligament, they attached on these 2 points. So ischium is very important for these ligaments. Then there's a pubis bone. Now pubis is actually the anterior part of hip bone. Okay, this is the, see, this is pubis. This much is the pubis. Now this is the body of pubis front. This is the body of pubis, and then it gives 2 rami, superior and inferior pubic rami, and both these rami, they attach to the ischium. Okay, so these are the superior pubic rami, inferior pubic rami, and the body of the pubis, it has the pubic crest. Here it will be the pubic crest and the pubic tubercle, and it articulates the pubic bone of opposite side, and it make a joint with the opposite pubic bone, which is called the pubic symphysis. Okay, so in the lower part of hip bone, see, this is the lower part, and here what is there? This is called the obturator. There's a large opening. It is called obturator foramen, and it is bounded by parts. See, both the parts. The ischium also making boundary of this obturator foramen and also the pubis. Okay, so this obturator foramen, it is filled by the obturator membrane. And what passes through the obturator foramen will be the obturator vessels and nerve in the obturator canal. Okay, I'll be discussing it later. See, this is the obturator membrane. The obturator membrane is a fibrous sheet that almost completely closes the obturator foramen. Okay, so this is a whole sheet, obturator foramen, leaving a small gap, the obturator canal, for the passage of, because the name indicates, you don't have to remember anything. The obturator canal contains the obturator nerve and the obturator vessels as they leave the pelvis to enter the thigh. Okay, so this is a very basic question. If they ask you the what it passes through the obturator canal, so that means that obturator nerve and obturator vessels, they pass through this canal. Okay, so move on to on ligaments. These are two very important ligaments. The sacrotuberous, the name indicates, from the sacrum to the tuberous. Okay, the sacrotuberous ligament is strong and it extends from the lateral part of sacrum and cox and posterior inferior iliac spine as well to the ischial tuberosity, starting from sacrum. Okay, and then goes to tuberous, means ischial tuberosity. If you see this diagram, then this is the insertion of the sacrotuberous ligament. This is the tuberosity, and see, this fans like this. It goes to the sacral wall, lateral sacral wall, the cox, and here will be also with the posterior inferior iliac spine as well on the back side. See, this is how the sacrotuberous ligament fans like. Okay, so this is the sacrotuberous ligament and the sacrospinous ligament. Again, the name indicates from the sacrum till the spine. So ischial spine is there on the ischium. The sacrospinous ligament is strong and it's a triangular shape. See, this is a triangle shape like this. See, this is the ischial spine and it arises again from the lateral part of sacrum and the cox. And apex is to the spine of ischium. Okay, see, it's a triangle-like shape. So these two ligaments, when these two ligaments, they attach and they convert, see, this was the greater sciatic notch and here it was a lesser sciatic notch. So when these two ligaments, they attach, they form, they divide the notches into two foramina. So upward is the greater sciatic foramina and below is this, the lesser sciatic foramina. Now these two foramina are very important for exam purpose as what passes through which foramina, and you have to remember this. This slide is so very important for exam, and I've just bold on the few points that are very important. So if you can remember what passes through the greater sciatic foramina, see, through the greater sciatic foramina, everything goes to the gluteus or buttocks, you can say. So you remember what goes through backside, gluteus for the leg as well. Okay, so see, sciatic nerve, it has to go back because it provides the nerve supply to all the legs and the buttocks. Superior gluteal nerve, inferior gluteal nerve. So everything which has to go back will be the greater, passing through the greater sciatic foramina. Then this is the posterior femoral cutaneous nerve, and then this is the nerve to obturator internus. Obturator internus also goes to the legs, it attaches to the leg, and nerve to quadratus femoris. So these are the very important nerves which passes through this greater sciatic foramina. And then again, see these two vessels, superior gluteal, inferior gluteal. See, all the gluteal nerves and vessels, they pass through this greater sciatic foramina. That you can easily remember, okay? So now a very important thing, this is the pudendal nerve and pudendal vessels, okay? So pudendal nerve and pudendal vessels, internal pudendal artery and vein, it passes through the greater sciatic foramina, it goes back, and then this is the lesser sciatic foramina. So lesser sciatic foramina is for the contents to enter to the perineum. So whatever wants to enter to the perineum, it has to go through this lesser sciatic foramina. So basically why pudendal nerve goes through the greater sciatic foramina is, it's just a biologically, you can remember that it just go backward, go outward through the pelvis, through the greater sciatic foramina, and then re-enter the pelvis. So from greater sciatic foramina, it goes outward, and then it re-enters through the lesser sciatic foramina to go to the perineum, because pudendal nerve is main nerve supply and blood supply for all our perineum. Okay, so this you have to remember, that all the pudendal nerve and pudendal vessels, they go from greater sciatic foramina and then re-enter through the lesser sciatic foramina to supply the perineum. Okay, so this is the similar, you can say, to the both. And then also the obturator, the nerve to obturator internus, nerve to obturator internus, this is also an additional point which goes from greater to lesser sciatic foramina. Okay, now one, if they ask you what muscle goes through these foramina, so the muscles will be one each. Okay, from greater sciatic foramina, the piriformis muscle. Piriformis muscle, it has to go through the greater sciatic foramina, and it will be attaching on the greater trochanter. Okay, and the obturator internus tendon, it will go from the lesser sciatic foramina, and it also has to attach to the greater trochanter. Okay, so these are the two muscles. If they ask you what muscle goes through the greater sciatic foramina, then this is the piriformis, and what goes through the lesser sciatic foramina, it will be the obturator internus tendon. It makes a tendon, and then it attaches to the trochanter of femur. Okay, so this is very important slide to remember, and I don't think you can remember with the mnemonic, but you just have to know the basic understanding of this anatomy, okay, what goes to what region. Okay, so everything which have to go to perineum, it must have to pass through the lesser sciatic foramina, which is the pudendal nerve, the nerve to obturator internus, then the internal pudendal artery and vein, and then the obturator internus tendon. Okay, so pudendal and the nerve to obturator internus, they also go through the greater sciatic foramina. I told you previously, it just make a loop like this. It first exits the pelvis, and then again it enters the perineum. Okay, so this is a different thing. And if they ask you, okay, what goes through the greater sciatic foramina and also enter the lesser sciatic foramina, okay, so these are the two nerves, nerve to pudendal and nerve to obturator, and only the vessels would be the internal pudendal artery and vein. Okay, so if they ask you about what exits the greater sciatic foramina, then all these nerves are present: sciatic, pudendal, and all the gluteal. See, gluteal nerves, femorocutaneous, the nerve to obturator internus, quadratus femoris. Okay, so you can just remember that which nerves they have to go to gluteus, or you can say the thigh. So they have to exit through the greater sciatic foramina. Okay, so that's a very easy way to remember the contents of greater and lesser sciatic foramina. Okay, and muscle you can remember because there is only one muscle. If you see the diagram, or can discuss later the origin and insertion of piriformis, then you also can remember that piriformis, okay, it goes through the greater sciatic foramina, and the obturator internus, it goes through the lesser sciatic foramina. This one muscle you can remember like this. Okay, so this is a very important slide. You have to remember it by heart because they can ask you which nerve exits the greater sciatic foramina, or which vessels enter or exits the greater sciatic foramina. Okay, so all these vessels, all these nerves, and this muscle, these are through the greater sciatic foramen. Okay, everything, I hope everything clear up till now. So we move on to our next slide. Okay. So these are just two joints, two pelvic joints, and which is first would be the interior, would be the pubic symphysis joint, and you just have to remember that pubic symphysis is a secondary cartilaginous joint. Okay, and the sacroiliac is a synovial joint. These two are very important exam questions. I have seen them multiple times. They are asking about which type of joint is the pubic symphysis and which type of joint is the sacroiliac joint. Okay, so this is just, you have to remember the type of joint, nothing in detail. So now this is a very important. Now we are moving to the pelvis. So pelvis is divided into a false pelvis and then a true pelvis. Now how we divide the pelvis into these two categories? Okay, if you remember, I told you that this was the iliopectineal line. Okay, and if you connect it through the sacrum, the iliopectineal line, and here will be the pectineal line, pubic crest. See, this whole thing is called, also called the, you can say, linea terminalis or pelvic brim. Okay, so this is a pelvic brim. It is very important landmark for obstetrics as well. So anything above this pelvic brim will be called the false pelvis. Okay, because this is not the pelvic part. This contains, this false pelvis, it contains the gut loops and everything, every pelvic organ else. But the true pelvis is below this pelvic brim. Okay, which enters the pelvic brim is actually the pelvic organ. Okay, so above this pelvic brim, you cannot say okay, because these are the hip bones, so if anything present here, so this will be the pelvic organ. No, this is the false pelvis. Okay, so these are very broad iliac crest, and everything above this pelvic brim will be the false pelvis. So false pelvis, this lies above the pelvic brim. So for false pelvis, it lies above pelvic brim. It is of little clinical importance and its boundaries. Now, on in the pelvis, the boundaries are very important. Okay, you just have to remember all the boundaries. What is anterior? What is posterior? If you just see the figure, you can remember. You can jot down all the boundaries. See, I told you, okay, the pelvic brim here, it above the pelvic brim is the false pelvis. Okay, so what would be the posterior? So posterior upward above the sacrum would be the lumbar vertebra. Okay, so posterior will be the lumbar vertebra. Okay, then laterally see, these are the iliac fossas. All this iliac fossa, and I told you in the previous, iliacus muscle is here. So iliacus muscle and iliac fossa would be the lateral boundary of the false pelvis. And what would be the anterior? Anterior, see, there is no pubic symphysis would be in the false pelvis because below pelvic brim will be the true pelvis. So above this pelvic brim, then there is no bony structure. Okay, above this pelvic brim will be the anterior abdominal wall. So the anterior abdominal wall will be forming the anterior boundary of false pelvis. Okay, see, there is no exact bony landmarks for the false pelvis. That's why it's of no clinical importance. Okay, what has the clinical importance is actually this true pelvis. So, so true pelvis is everything which lies below this pelvic rim. Okay. So why it is very, very important? Because this is the bony canal through which the child passes during birth. Okay. In obstetrics, the child enters the birth canal. You can say the birth canal, bony canal. So this pelvic brim, when when the fetal head enters this pelvic brim, then only it can be, we can say, the engagement of the fetal head. We'll discuss in our fetal skull lectures. And so the child passes during birth through this true pelvis. Okay. So now there are three parts of this pelvis. Okay. First, I told you that this is the pelvic brim. You can call it as pelvic inlet. Okay. Then in the outward, there will be pelvic outlet. And in between these two, inlet and outlet, would be a cavity. Okay. Upward is the inlet, below is the outlet, and in between is the cavity. Okay, so we will be discussing all the boundaries of these pelvic inlet and outlet. So the pelvic inlet or the pelvic brim, it is bounded. Now see, what are the boundaries of inlet? This is a pelvic brim. Now posteriorly, I told you that upper is the, anteriorly is the sacral promontory. Okay, so posteriorly would be the sacral promontory, and laterally, see, this laterally is the iliopectineal line. We discussed it previously. This line is very important. Okay, so both on both sides, these are the iliopectineal lines, and anteriorly would be the symphysis pubis. So these are the three boundaries of the pelvic inlet, and this is a very, very important exam question. They can ask you, okay, what is the posterior boundary of pelvic inlet? Okay, so you can just remember this figure, and you can just select the sacral promontory. Okay, and what would be the lateral boundary? Lateral boundary, because we know that pelvic inlet or pelvic brim is formed by this iliopectineal line. So the iliopectineal line, or it can be called as arcuate line. You have to remember all the names of these lines, okay? So this arcuate line would be the lateral boundary of this pelvic inlet, and anteriorly will be the symphysis pubis, okay? So this is the pelvic inlet boundaries. Now, what is the pelvic outlet? If you see from below, this figure is from below. So this blue dotted lines, this forms a pelvic outlet. See, it's a little bit a diamond shaped pelvic outlet, okay? So how it is formed? If you see this posterior point posteriorly, what's this? It's a cox. So posteriorly would be the cox. Okay, then laterally what would be here? Lateral. If you see this, these are sacrotuberous, ischial tuberosities. Okay. Now ischial tuberosities are here, and you see this ligament. So what ligament will be attaching to the tuberosity? It would be a sacrotuberous ligament. Okay. So posterolaterally, see, this is a lateral but posterior border. Posterolaterally would be this sacrotuberous ligament. And then if they ask you about anteriorly, you can say the ischiopubic rami. You can say this is an ischiopubic rami and the lower border of pubic symphysis. Okay, but all this can be called as pubic arch. Okay, if this name is not there in the MCQ, the pubic arch, then you can look for the ischiopubic rami. See, this is the ischiopubic rami and then the pubic symphysis. Okay, now you understand all the boundaries of this outlet. Posteriorly would be the cox, laterally would be the tuberosity, posterolaterally the sacrotuberous ligament, and then the anteriorly, if the pubic arch word is not, because this is the pubic arch. Two pubic bones, they attach and they fuse, they form an arch. Okay, so this is a pubic arch, or you can say this is the ischiopubic rami and the pubic symphysis. Okay, so these are the boundaries of pelvic outlet. Now there are three white notches in the pelvic outlet anteriorly. See, this is the pubic arch. You can say it's a notch. Okay, because the angle of this arch is very, very important for pelvis. And laterally would be the two sciatic notches you discussed previously, the greater sciatic notch and the lesser sciatic notch, okay? So these three notches are in the pelvic outlet. Now the sciatic notches are divided by these ligaments into the foramina. We discussed it previously, okay? So these are the boundaries of very important pelvic inlet and outlet. They can ask you what makes the boundary, what makes the interior boundary of pelvic outlet, or what makes the posterior boundary of pelvic outlet. So these boundaries are very important, pelvic inlet and pelvic outlet, okay? Now, what's inside the pelvic inlet and outlet? I told you that above is the pelvic. See, if you say this is the pelvic inlet, okay, from the pubic symphysis to the sacral promontory. And then this will be the outlet from the pubic symphysis till the cox, okay? So everything inside this would be the cavity, okay? So this is the pelvic cavity. The pelvic cavity, it lies between the inlet and outlet, and it is a short curved canal. If you see that it is a curved canal, how? That anterior wall is the very smaller one, the shallow, you can say shallow anterior wall, and posterior wall is deep, okay? So it is a curved canal. Now, what is the axis of pelvis? Axis of pelvis, if you say this is the pelvic inlet and you take the center point of this inlet and the center point of this outlet, okay? If you draw an imaginary line through these center points, it doesn't go through the center point, okay? If you draw this imaginary line through these center points, then it would be the axis of pelvic cavity. And why this axis is important? Because the baby actually, fetal head has to pass through this axis, okay? So the axis is an imaginary line joining the central points of AP diameters from inlet to the outlet. And it is the curved course taken by the baby's head as it descends through the pelvis during childhood. Okay, so this is a very important axis as well. No need to remember these diameters. I'll be discussing it later. Okay, so up till now, the boundaries of pelvis was very important. You have to remember what makes the interior border, posterior border of pelvic inlet and outlet. Now, this topic through the whole pelvis, these diameters are very important. You have to remember these diameters, and it's a very important exam question as well. Now, again, we are going to the pelvic inlet. What we were discussing that, see, like this was the pelvic inlet. This is the pelvic brim I have drawn. Now, how many diameters of the pelvic inlet? If you see this, what I have drawn, it is an AP diameter. You all know anterior and posterior diameter. AP diameter and posterior. And this is called as lead diameter. Okay. So these three diameters we will be discussing of all the pelvic inlet, then outlet, and the cavity. Okay. So these three types of diameters you have to remember the centimeters as well. Okay. So what is the next? The AP diameters. Now there are three AP diameters of pelvic inlet. Only of pelvic inlet, there are three AP diameters. Okay. One is called the true conjugate. See, it's written here. Then is called T O T. You have to remember. This is a true conjugate. Now, middle is the 10. Above is 12 and below is 12. Above is 11 and below is 12. Now, this centimeter is very important. You just have to remember this. Okay. Now I'll tell you what are these diameters. See, this is the true conjugate in the diagram. You see, what is this? Above front this is the pubic symphysis. Okay. And what is this? Sacral promontory. Now, all the diameters of pelvic inlet, they are coming from the sacral promontory. Okay. So if this is the true conjugate is from the sacral promontory to the upper border of pubic symphysis. See, this is the upper border of pubic symphysis. Okay, so that would be called the true conjugate. Now again, if you see the next diameter, the obstetric conjugate, it again arises from sacral promontory, but it goes to the middle of pubis. See, this is the pubic symphysis, so it is the middle of pubic symphysis. Now, what happens with the diagonal conjugate? Again, from the sacral promontory, and it goes to the lower border of pubic symphysis. Now, you just remember how I write the TOD. T is above, so it is the upper border of pubic symphysis. O will be the middle point of pubic symphysis, and D would be the lower border of pubic symphysis. Okay. Now, if they ask you from where the true conjugate arises or where the obstetric conjugate, you just have to know TOD. Above is to T through, middle is the O, and lower is the D. Okay. So, what are actually these conjugates from the midpoint of sacral promontory to the upper border of pubic symphysis? Okay. Now, I told you previously it is a 11 centimeter conjugate, true conjugate. Okay. Now, what is the obstetric conjugate? Basically, this conjugate, obstetric conjugate, is very important. The name indicates it is important obstetrically. Okay. Why it is important? It is the most important AP diameter of pelvic inlet, as it is the one through which the fetus must pass. Now, all the diameters, all the canals through which the fetus has to pass during labor, those diameters would be important. Okay, so true conjugate, diagonal, they're not be using by the fetus. So that's why this obstetric conjugate is important, because the fetus has to pass through this diameter. Okay, so anteroposteriorly, the obstetric conjugate is important. Now, from how it is measured from middle of symphysis pubis. Okay, see, you remember TOD. So obstetric would be the middle symphysis pubis, and again the sacral promontory. Okay, now what should be this obstetric conjugate? For normal delivery, it must measure from 10 centimeter or more. Okay, so we remember O and 10. Okay, so this O. Okay, so again my screen sharing stopped. Okay. So, okay, sorry for the interruption. Again, actually my screen share, I don't know what's the problem. It stopped automatically. So what are we discussing? The obstetric conjugate, it should be at least 10, because if it is less than 10, the pelvis would be considered to be contracted. Okay, and why the baby could not pass through this? Because in all the obstetrics we discussed that the fetal head diameter, should be 10 centimeter. So every diameter should be more than 10 centimeter to pass the fetal head. Okay, so that's why the 10 centimeter uh, is very important. Okay? Now, what's the problem? It cannot be measured clinically. We cannot measure this obstetric conjugate diameter. So we we have just tried to how you can measure? We subtract few centimeters, 1.5 to 2 centimeter, 2, you can take 2 from the diagonal conjugate. Okay, so what we were discussing, TOD, TO was 10, upper 11, below 12. If you subtract 2 centimeters from this diagonal, it would be 10. If diagonal would be 13, then obstetric would be 11. So it is more than 10. See, this is how we determine the obstetric conjugate and the significance of this diagonal conjugate as well, because only the diagonal conjugate is basically you can measure, not other diameters. Okay, so this is the diagonal conjugate, and how you measure? You insert 2 fingers through the vagina and you go your finger up till the sacral promontory. From another finger, you just make a point that here is the pubic symphysis, lower border of pubic symphysis. Okay, and then after withdrawing your hand, you just measure the length of this. Okay, just measure it. See, this is the lower border of pubic symphysis, and here the finger goes to the sacral promontory. Okay, so if this diameter is you measured is more than 12 centimeter or more, okay, if this is 12, then obstetric would be 10. Okay, so that's the significance of this diagonal conjugate, because only we can measure this diameter, and if this is more, then we just assume that okay, minus 2 centimeter, so the obstetric conjugate would be more than 10 centimeter. Okay, so it means okay, this is good enough for the fetus to pass through this pelvis. Okay, so this diagonal conjugate is measured from midpoint of sacral promontory to the lower border of pubic symphysis. Out of 3 diameters, only this can be assessed clinically during the late pregnancy or at the time of labor. You just assess. Okay, so these 3 diameters, you just have to know the basic knowledge, and then you can remember easily like what is the diameter of obstetric, true, and diagonal conjugate. Okay, 10, 11, 12. Okay, so this is they can ask you. Okay. So move on to our next diameters. We are now dealing only with the pelvic inlet. Okay, so we just have finished our AP diameter. Now what would be the next? Would be the transverse diameter and oblique diameter. Okay, if you see this figure, you see this is an AP, now this is the transverse and this is the oblique. Okay, so transverse is from where? These 2 points. Okay, what are these 2 points? Where are these 2 points? These points are on ileo. So now how the transverse diameter called? It is the distance between the farthest 2 points on the iliopectineal line. Okay, and it is the largest diameter of pelvic inlet. So in the pelvis, actually the female pelvis, you can say the gynaecoid pelvis is like this shape. The inlet is oval shape. So oval means the transverse would be more. Okay, you just have to remember the shape. This is an oval shaped pelvis. So the transverse would be more. So transverse would be 13 centimeter. Okay, and you just need to remember that all the oblique diameters of inlet, outlet, and cavity are 12. This is very easy diameter. You can remember that all the oblique diameters are 12 centimeter. Okay, so what are the 2 oblique diameters? Now this is an oblique diameter, and again this is an oblique diameter, right and left. Now how you called, what would you call the right? So the right diameter passes from right sacroiliac joint. Okay, so it passes from this sacroiliac joint to the left iliopubic eminence. Okay, again the iliopubic iliopreced line on the iliopubic eminence. Okay, so the right oblique diameter, it starts from right sacroiliac joint and goes to left iliopubic eminence, and then the left one starts from left sacroiliac joint and goes to the left iliopubic eminence. Now here you have to remember that right diameter would be starting from right sacroiliac joint, okay, and then goes to left side. So this point, starting point, is important, that sacroiliac joint would be on right side, okay. You cannot say that right, you cannot say up backward like this, that no, the right iliopubic eminence left joint, that would be right oblique diameter. No, the right oblique would be starting from right sacroiliac joint, okay. So that's just the important thing. And diameters, it's a very important, very easy way to remember. I'll be discussing later as well. The pelvic inlet, okay. I told you this is an oval shape, okay. So oval shape means transverse would be more, so 13. And what's the opposite thing? Transverse and then the AP. So AP would be 11. And oblique, because all obliques are 12. So 13, 12, and 11. Okay, and it's the very opposite in the pelvic outlet. I'll tell you in next slide. Okay, so again, a very important and easy way to remember, the diameters of pelvic cavity is almost round in shape. So when anything is round, so all the diameters will be equal. Even you say oblique, you take AP and you take transverse. So anything which is round in shape, all the diameters would be equal, and so as it is 12 centimeter each. So all the obliques are 12 centimeter, okay, and all the diameters of is round. So all the 12 centimeters. Okay. So what would be the anteroposterior transverse diameter? So an AP diameter. AP diameter, how it started? See, from front, it started from the pubic symphysis, lower border of pubic symphysis, and where it goes, see this point, it goes to cox, tip of cox. So this is the AP diameter. Okay. And then it measures from 11 to 13, you can say, depending on the position of cox. Basically, it is, you can say it is 13 centimeter, okay? Because this outlet, we discussed previously, the boundaries of outlet, again, you can revise. Posteriorly is the cox, laterally, posterolaterally, the sacrotuberous ligament. See, this is, and laterally would be the ischial tuberosities, and anteriorly the ischiopubic rami and the pubic symphysis. See, these were the borders of the pelvic outlet. Now the diameter would be in the center. Okay, so here the AP diameter is longest in the pelvic outlet. Just have to opposite the pelvic inlet diameters. Okay, so longest means it would be 13 centimeter. Okay, so transverse diameter. Transverse means what was the lateral points? The lateral would be the tuberosities. Okay, so this lateral transverse diameter can also be called the intertuberous diameter. Okay, because on lateral side, the ischial tuberosities were present. Okay, so this is 11 centimeters. See, I told you that whichever wall is longest, the opposite one will be the, see this. This is how the pelvic outlet shape, like a diamond. So this is the AP diameter is longest, so it is 13. The transverse shortest, you can say it would be 11, and all the obliques are 12 centimeter. Okay. Now, and one again thing important, subpubic angle. You can say this, we discussed previously that this is a pubic arch. Okay. So it makes an angle. This angle is very, very important for obstetric purpose, because the pelvis has to be wide so that the head passes through this outlet. Okay, so this pubic angle is very, very important. See this angle. It is the angle between two descending pubic. So 90 is the cutoff. 90 is the cutoff for the subpubic angle for the pelvis to deliver normally, because the head passes through this angle. If the angle is very acute like this, you can say it's less than 90 or 60 degree. So that would be a contracted pelvis. Okay. So these were the diameters of pelvis that you have to just remember all these diameters. And this table is just jot down all the previous diameters, and you can easily remember. First, you have to just understand all the diameters, and you have to understand the knowledge of those diameters and boundaries. Now you can remember this very easy way. I told you all the pelvic cavity diameters are 12 because pelvic cavity is round. Okay. Now pelvic inlet, I told you it is like an oval shape. So oval means transverse is greater. So which thing is greatest? The opposite thing would be smallest. 11 AP. Now the pelvic outlet, I told you it's a diamond shape and it is like this. So this shape AP would be more. So AP is 13 and shortest would be transverse. Okay. All the obliques are 12. See, all the obliques in inlet cavity and outlet are 12. So this is a very easy way to remember because you can actually forget these diameters, but this is an easy way to remember. So you just have to have a basic knowledge of all the diameters, the boundaries. They are very, very important. And then these centimeters, they come in exam usually. Okay. So anything up till now, you can ask any question from these diameters. If you have any doubt, you can ask me. I can tell you again. Okay. But this is clear. I move on to our next slide. No question. Okay. So, sorry, excuse me. So these are the types of pelvis. Okay. These are the 4 types of pelvis. This would be the gynecoid pelvis, is actually a normal female pelvis. It is a very common percentage of this pelvis. Then there would be the anthropoid is 25%, and then the android. See the heart shape. The heart shape is a male looking pelvis. You just have to remember it like this. Gynecoid oval, this is a female pelvis. Okay, just remember like this. The oval inlet, and this is the platypod. It is also an oval, but it's a very flat. You see the AP diameter is very short here. So for head to enter is very difficult. So this is a very long oval. You can say it's a platypod, and it is a least common. So if they ask you what is the most common type of pelvis, it would be the gynecoid, and the least common would be the platyploid. Okay. And what type is the male? Okay, so these are the few points in pelvis. You can see the differences of these pelvis. You just have to have the understanding of these pelvis, and there are just few things that are important for exam purpose. Okay, so we discuss everything. This is a gynecoid, the female type pelvis. See, this is the oval transverse diameter will be more. So transverse diameter of inlet is slightly bigger than AP diameter. Okay, not very bigger like this. See, this platyploid, very bigger transverse diameter. Okay, that's the difference between these two. Now the subpubic angle, we discussed previously, it should be more than 90. So 90 to 100 majority. Okay, so the gynecoid pelvis has everything that is feasible for the normal delivery. Okay, so the inlet is transverse oval, transverse diameter is just bigger than AP, pubic angle is 90, the pelvic side walls are straight and parallel. Okay, so for the fetal head or fetus body to accommodate, and the ischial spines, they are not prominent here. They should not be prominent actually for the labor and for the head to descend into the outlet. And obstetric outcome is very good. The normal female pelvis, no difficulty in engagement. The most common position of head would be left occipital transverse, occipital anterior. You don't need to go into details of these occipital anterior and occipital transverse, but you just know that, okay, this is the very important and very this is a normal female pelvis, and the type of delivery would be normal delivery and easy delivery in this type of pelvis. Okay, so now the android pelvis. See, this is a female type pelvis. Okay, now what's the difference between the female and male looking? That's important for you. Okay, so this, see the shape of inlet. This is the heart shape. This is a very important point. Heart shape. Again, the transverse diameter is more than AP diameter because this is a heart shape. But the difference would be less than 90 degrees subpubic angle. Okay, so this is a very important difference for a male looking pelvis because the angle would be, subpubic angle would be very acute and its side walls would be convergent. Like side walls would be inwards. And also the prominent ischial spines. If you see this diagram as well, you see their ischial spines, they are seen. And you can, during examination of laboring patient, you can feel the ischial spines. They are very prominent. Okay. So here the delivery would be difficult, the engagement would be delayed, deep transverse arrest because the head would not be rotated. Okay. So the difficult instrumental delivery occurs in this type of pelvis. Okay. So now the anthropoid pelvis, the ape-like pelvis. So this is the transverse. Now this is oval like ape in AP. Okay. Also this is an oval shape. Now again, what is the, it's AP oval, and here the AP diameter is more than transverse. Now in all the types of pelvis, you see here the transverse is more, here also transverse diameter is more. Platyploid also transverse diameter of inlet is more. Only this type of pelvis, because this is, and you can say the oval is shifted in the AP anteroposteriorly. So the AP diameter is more than transverse only in this anthropoid pelvis. Again, the pelvic side, but here the problem would be the diameter of engagement is AP diameter. So occipital posterior position will be common and the head could not be rotated because all three, this is the inlet, the outlet would also be the same, like AP diameter would be longest. So face delivery occurs in this anthropoid pelvis. And then move on to our last type of pelvis would be the platyploid. And I told you that it is a least common and it's a flat. And in here, it's a very long oval shape. See, it's a flat bowl-like. And the transverse diameter is much, much more than the AP. Okay. So here the walls are divergent and not prominent, but head actually engage in transverse diameter and there would be marked asynclitism. You just don't need to remember all these points. You just can say the engagement would be difficult and rotation would also be difficult to occur in this type of pelvis. Okay, so these are the few differences in these types of pelvis, in the pelvis types. But the important things are these: the male pelvis and gynecoid. For example purpose, you just need to remember the differences of these pelvis. That's important. I told you previously this male would be, the inlet would be heart shaped and the female would be the transverse oval. The side walls would be convergent and here the side walls are parallel. The pelvic cavity would be deep and narrow pelvis. Okay, see, this is the male pelvis, the deep and narrow, like this. And here the female pelvis, the shallow pelvis. The pelvic cavity is very shallow and it is broad. Okay, and ischial spines are prominent here in the male pelvis and ischial spines are not prominent. And the angle, the very important difference between these two pelvis is angle. See, if you see this arch, this is a very acute angle. Okay, so it would be less than 90. And here in the female pelvis, the angle would be very bigger, so more than 90 to 100. Okay, so that's very important slide for your exam purpose as well. The difference between an male pelvis and female pelvis. So male pelvis would be called android pelvis and female would be gynecoid pelvis. Anthropoid and platypoid, you just have to you just understand the main diameters of inlet. That's all the differences you need to remember. Rest, the android and gynecoid pelvis, you just have to remember the differences. Okay, so move on to our next topic. It is our pelvic floor. We'll be discussing just a few slides of pelvic floor and pelvic floor muscles, okay? So basically, floor of pelvis, actually it supports the pelvic viscera and it is formed by the pelvic diaphragm. Okay, the floor stretches across the pelvis and it divides into two main pelvic cavity above. So the pelvic floor is this, if you say, and above the pelvic floor would be the pelvic cavity, okay? And below this pelvic floor would be the perineum. Perineum is actually very, very important topic we'll be discussing in our next lecture, perineum. So this is the floor. So by entering the floor, you just, by bypassing the floor, you enter into the perineum. Okay. So how this pelvic floor is formed? It is formed through this pelvic diaphragm. So pelvic diaphragm is actually formed by very important two muscles. The one is the levator ani muscle, and the smaller second is the coccygeus muscles, and also the covering fascia. So it is also incomplete anteriorly to allow passage of urethra in males and urethra and vagina in females. I'll tell you in the next slide. See this slide. Okay. See this slide. This is a whole sheet of muscles. You know, this is the pelvic floor. Now, where it is absent, see this gap. Okay. So this is the pelvic floor. It is absent anteriorly because the urethra, the vaginal opening, everything has to pass through it. So it is absent anteriorly. Okay, so the levator ani, it is a very important muscle and its origin and insertion. If you just see this diagram, I'll be reading later on. If you just see this diagram, that from where the levator ani arises, see its origin. If you see, what's this part called? Now there is no no origin from pubic symphysis. Okay, so this would be the pubic bone. Okay, so this is the pubic bone, and then what would be here? This part is actually, if you see the lateral view, then this would be actually the obturator internus covering fascia. Okay, so here the pubic bone, the obturator internus covering fascia. So these are the, and this is the third point would be the spine of ischium. Okay, so these are the origin points of levator ani muscles. Okay, so what happened, how it arises and how it inserted. See the most anterior fibers. Okay, so the most anterior fibers of both sides, they come in the middle and they fuse at the perineal body. Okay, now these muscles would be calling the levator, prostate, or sphincter vagina. Okay, the thing which encloses the muscles that encloses, you can say, the vaginal opening. See, this would be the vaginal opening. So this muscle, this part of this levator ani would be called levator sphincter vagina or levator prostate in males. Okay, now so these are the very anterior fibers. Okay, now you can say middle fibers, middle or intermediate fibers. Now what would be they would be arising from this pubic bone, and they surround this anal canal. See, this is the anal canal, and they surround the anal canal, and they goes to this anococcygeal body. If you see this diagram, this is an anococcygeal body. Okay, so they goes to like this, and they form a sling-like action. Okay, now this part of muscle is called puborectalis. Now the rectalis word is coming, so you say this is the covering the rectal canal. Okay, then also the few muscles are pubococcygeus as well. Now the few muscles of, again, the intermediate fibers, the few are puborectalis, you can say, and the few are pubococcygeus, which goes to this coccygeal body. All the muscle, these are intermediate fibers, you can say. Now the posterior fibers, if you say these are the posterior fibers. Now from where they are arising from obturator internus fascia. Okay, and where they are going. Now these fibers are going to the cox and the inococcygeal body as well. Okay, see, this is the posterior fibers. Now, what it is called? It is called the iliococcygeus muscle. Okay, so that was about the levator ani, and if you read this, the origin. So the levator ani is a white thin sheet. It arises from the back of body of pubis, like anteriorly. Then the tendinous arch formed by thickening of fascia covering the obturator internus, and then the spine of ischium. Okay, so how it inserted. Its insertion points are different because anterior fiber, the levator, prostate, or sphincter vaginae form a sling around the prostate or vagina. Okay, and are inserted into a mass of fibrous tissue which we call the perineal body. Okay, so they are inserted to the perineal body. So these are the most anterior fibers. Okay, now the intermediate fibers, the which we called puborectalis and pubococcygeus. So puborectalis forms a sling around the rectum and anal canal. Okay, so this would be the puborectalis, and the pubococcygeus passes posteriorly to be inserted into a small fibrous tissue, which would be called the anococcygeal body. And this body is between the tip of cox and anal canal. So this is the cox, and this is the anococcygeal body. So these pubococcygeus muscles attaches to the name indicates pubococcygeus means it attaches to the coccygeal body. Puborectalis means it surrounds the rectalis. Okay, and here the sphincter vaginae means it form a sling like action around the vagina. So the name indicates the origin, insertion, and the function of these muscles. Now, the posterior fibers, the name indicates the iliococcygeus is inserted into the anococcygeal body, cox, and the cox. Okay. So the very important function of this levator ani muscle, the levator ani muscles of the two sides. Now they form an efficient muscular sling that supports and maintains the pelvic viscera in position. See, they are giving a support to all the pelvic viscera. Okay, and they resist the rise in intrapelvic pressure during straining, like cuffing and expulsive efforts of the abdominal wall muscles. Okay, so they resist the rise in intrapelvic pressure, and they also have an important sphincter action on the anorectal junction. Like we discussed, sphincter action on vagina as well, and sphincter action on anorectal junction as well. Okay, sphincter of vagina and anorectal junction. So sphincter-like action they have, then they resist intrapelvic pressure, and then they support the viscera in position. Okay, so in position means if this levator ani muscle is disturbed, or then what happened if pelvic viscera would not be in position? What happens? It would be prolapse. So one thing very important, the function of pelvic floor muscle, the levator ani, is to prevent from the prolapse. Okay, and then again the intrapelvic pressure during straining, if it is resisting. So what happened if levator ani muscle is destroyed? Then it would be gone to the stress incontinence, stress urinary incontinence. Okay, whenever the increase in intra-abdominal pressure, there would be the leakage of urine, and the sphincter vagina action on anorectal and sphincter vagina as well. Now, the nerve supply of this levator ani would be the fourth sacral nerve. So S4 is very, very important. S3, S4, actually, the pineal branch of pudendal nerve is also supplying this levator ani muscle. Okay, so this is a coccygeus muscle. It is a very small muscle. If you see on this diagram, the coccygeus muscle. So this is actually the coccygeus muscle. Here it arises and it goes to here. Okay, so it is actually a very small muscle, but again it is forming the pelvic floor with the levator ani. So it has significance. So this is small triangle muscle. It arises from spine of ischium and lower end of sacrum, and inserted into the sacrum and into the cox. Okay, so the two muscles, they assist the levator ani in supporting the pelvic viscera. Again, the S4 and S5 sacral nerves, they are supplying. Okay, so this was all about the pelvic muscles. We have discussed two muscles, but I skipped actually these two muscles. These two were the pelvic walls muscles, And these two muscles were the pelvic floor muscles. See, levator and coccygeus are pelvic floor muscles. But the piriformis and obturator internus, okay, these two muscles we discussed previously for in the foramina. So from where the piriformis it goes through the greater sciatic foramina, okay, and obturator internus lesser sciatic. So that was the significance of these two muscles. You don't have to just remember their origin and insertion. The blood supply, nerve supplies of muscles are important, and anything unique to the muscle. So this piriformis through the greater sciatic foramen is important. The obturator internus through the lesser sciatic foramen it is important. Okay, so piriformis arises from a front of sacrum and goes to femur. So both these muscles are attaching to the greater trochanter of femur. Again, obturator internus, the name indicates it would be originating from obturator membrane. Okay, so nerve supply of piriformis would be sacral plexus, and the obturator internus was the nerve to obturator internus. So that nerve, you remember, if you remember the foramina, we discussed the nerve to obturator internus. It goes through the greater sciatic foramina and also the lesser sciatic foramina. Okay, so that nerve was unique with the pudendal vessels and nerve. It enters the greater sciatic foramina. First, it exits the pelvis through the greater sciatic foramina, and then it re-enters the pelvis through the lesser sciatic foramina. Okay, so that was the significance of these two muscles and this nerve as well. And both these muscles are lateral rotator of femur at hip joint. Okay, so muscle actions is also very important. If they give you a scenario of muscle weakness, so you have to select the which muscle is affected. Okay, so action is you have to remember. So levator 9 coccygeus, we have discussed all the origin and insertion and the nerve supply as well. The fourth and fifth sacral nerve, and actions are also support pelvic viscera, sphincter to inner rectal junction and vagina, and coccygeus also assist the levator ani to support pelvic viscera and plexus cones. Okay, so up till now, any question you want to ask? Because that's the end of our pelvis portion, and we'll be discussing in our next lecture would be the perineum. Okay, because perineum was very big if I attach to this pelvis, so that would be a very big lecture. So that's why I cut it up till here, the pelvic wall muscles. So we'll be discussing perineum in our next lecture. Anything up till now you want to ask? Okay, the clinical significance. Actually, I told you previously that if the pelvic floor is injured during a difficult childbirth, then it can result in the loss of support for pelvic viscera. So the prolapse would occur, uterovaginal prolapse. The bladder can be herniated, the cystocele, and then the bladder neck position would be altered. So when the bladder neck and urethral position altered, then it leads to stress incontinence. Okay. So sphincter action, they would be disturbed if the pelvic floor muscles are injured during a childbirth. So that's why we say that in prolapse, the childbirth has a very, very important risk factor. So grand multipara, they have a very high risk of having a prolapse in their old age, because every time there's a normal vaginal delivery, there would be the damage to the nerves and the pelvic floor muscles. Okay, so that later on leads to the prolapse of uterus, vagina, or bladder, the cystocele. Okay, and later on they can have the stress urinary incontinence as well, even after pregnancy as well. Okay, so this is the end of our lecture. If any question you want to ask up till now, you can ask, or we have few questions if you want to just participate in those questions. Anything you want to ask? Okay, so we have few questions that are very important, and that's how the previous questions, past questions actually came in the exam. So this is the regarding elevator and eye, which of the following statement is true? Basically, they are asking you about the innervation. So what was the innervation of elevator and eye? Anybody can answer this question? No? No one can answer this question? Or I should be given the answer? Okay. So levator ani is innervated by, I told you that it would be from S3, S4 spinal nerves. Okay. So if you know the nerve supply, you can just correctly choose the correct answer. Okay. So which of the following leaves the pelvis via the greater sciatic foramina? Now that is the very, very important. That was a very, very important question. I told you that what enters and what leaves the pelvis through the greater sciatic foramina was very important. And whenever this question arises, either the greater or the lesser, wherever if you see the pudendal nerve or pudendal vessels, you just select this because pudendal nerve and pudendal vessels, they passes through both foramina. Okay, so you don't need to even see all the options. The pudendal nerve is actually leaves the pelvis by the greater sciatic foramina. Okay. So regarding the pubic symphysis, what type of joint it is, we have discussed that pubic symphysis is our cartilaginous joint. Now, what type is it? Is the secondary cartilaginous joint. Okay. So this is how the question come in exam. You just have to know the basic. Only they ask about basics. Okay. So what is the average AP diameter of female pelvic outlet? Anybody can answer this diameter? This was the outlet I have drawn. So the AP diameter. Anybody can answer? Anybody here? Okay. Oh, that's the problem now. I don't see actually chats. Okay, you are answering me E. So what is option E? 13. Okay, that's right. That's very good. So you were giving me answers and I was not actually seeing them. Okay, that's right. Very great. Good. So that's the 13. Okay. Now, what is obstetric conjugate? Obstetric conjugate in centimeter. You all must have known this. Now I have to see your answers. Obstetric conjugate. 10A. Yes, very good. Very good. Yes, from O you can remember that this is an 10 centimeter. Okay. Now this question is, you see a patient who is 32 weeks pregnant, complains of tingling to the right buttock and shooting pain down the leg. You suspect piriformis syndrome. Now what statement is true? Now, who can tell me the answer of this question? No, the option I will read the option of supplies via S2 to S4. Origin is ischial tuberosity. Insertion into the greater trochanter. Main action is internal rotation of hip. Was it internal rotation or lateral rotation? And then the arterial supply is by the medial sacral artery. So what are you giving me answers? Yes, Dr. M. Who is Dr. M? Tell me your name. Very good. It's option C. So both the muscles we discussed previously that both the piriformis and the obturator internus muscle, they goes to the greater trochanter of femur. So insertion point is greater trochanter. Okay. And nerve supply is actually from the sacral plexus. So the plane of pelvic inlet is at what angle to the horizontal? That I have not discussed with you. So if you know anybody know the plane of pelvic inlet, it is 15, 30, 45, 60 or 75. Anybody knows the plane of pelvic inlet? Dr. Manazza, very good, Dr. Manazza. Previously it was C and here it is D. Very good, very good. It's C, 60. So 60 is the plane of pelvic inlet. Okay. So that's all I think for today's lecture. Anything else you want to ask or you don't understand? This was actually a small lecture because I could not add perineum with this lecture because perineum was a very, very big topic. So I had to cut short then. Anything you want to ask? No, nothing. So let's close.